The following podcast is part of a certified educational activity titled Aligning Clinical Practice with Emerging Evidence, Navigating the Rapidly Evolving Landscape of Glomerular Kidney Disease Management. Access the entire activity and complete the post-test at peerview.com/XWR860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Carla Nestor from the University of Iowa. Welcome to this educational activity on the complement-mediated glomerular kidney diseases. Our goals for today is to understand how glomerular diseases differ from more common forms of kidney disease, focusing on the impact these differences have on how we screen for, diagnose, and treat the diseases. We would also like to recognize how new targeted treatments for glomerular disease work and how to select patients for glomerular disease for the latest targeted therapies, as shown by recent clinical trials. It's an exciting time in the glomerular diseases currently, and one of the most exciting things that we've seen recently is the publication of the newest or latest KDIGO glomerular disease guidelines published in 2021. These guidelines indicate the treatments for glomerular diseases in the form of essentially three separate categories: supportive cares, anti-inflammatory cares, or often referred to as nonspecific immune suppressants, and recently, the more targeted therapeutics. When we begin with supportive cares for most patients, we're often thinking of lifestyle changes, and this includes, for instance, salt control, cessation of smoking, weight control, etc. These are the primary lifestyle changes that we are going to be invoking for our patients. Then we're going to be considering more supportive cares that may be specific for a given glomerular disease. For instance, high-grade nephrotic patients may require anticoagulation. Regardless, you can see these in the latest update for the glomerular diseases in the KDIGO. The sooner supportive treatments are initiated, the sooner disease progression may be slowed. This is a very important concept moving forward. Many of these treatments can be initiated by local physicians or local nephrologists, primary nephrologists. They do not have to be referred to specialized centers to have these therapies to begin. Targeted therapies for glomerular disease are becoming more and more available, and there will be a learning curve involved with these. But this is the point of programs such as this, so that we can heighten the importance of early diagnosis and the importance of understanding what the underlying pathology is, so that we know how these targeted therapeutics may be useful. Once we have established our supportive cares, and we've done everything we can do to get that first part taken care of for our patients, then we will move to what we would consider to be more standard immune suppressants or anti-inflammatories. They are actually quite different for each of the glomerular diseases, so we do encourage you to refer to the KDIGO for a given glomerular disease, but they may include things like glucocorticoids or cyclosporin or even mycophenolate mofetil, for instance, depending on what the glomerular disease calls for or what's been studied in that given glomerular disease. That will be what's next before you get to any of the newer therapeutics. When we think about a couple of the newer supportive cares, we'll think about, for instance, sparsentan and atrasentan. Sparsentan is a non-immune suppressive dual endothelin angiotensin receptor antagonist. It blocks particularly the actions of endothelin-1 and angiotensin 2. It reduces the proteinuria in adults with IgA nephropathy, for instance, a very important new addition to the IgA treatment plan. And particularly, it reduces the progression to kidney failure. In the case of atrasentan, it's a selective endothelin A receptor antagonist, and it reduces the risk of developing end-stage kidney disease in the type 2 diabetic, also a wonderful addition to the type 2 diabetic treatment. Important to note for either of these agents is, again, they would be considered to be supportive cares, not necessarily targeted cares when we consider, for instance, the complement-mediated kidney diseases. We know that sparsentan reduces the proteinuria more than irbesartan, and we know this from the PROTECT trial. Particularly, sparsentan was shown to cause a slower rate of GFR decline in the treated group, sparsentan versus irbesartan, and there was a 40% change from baseline in the urine protein over the irbesartan group. Importantly, sparsentan can be used with SGLT2 inhibitors, and this was shown in the open label extension of the PROTECT trial. Particularly, adding SGLT2 inhibitors was shown to be safe and additive as far as protein reduction. When using sparsentan, there are a number of things to consider. This is not unlike other scenarios where the new agents come with some caveats. For instance, sparsentan does have drug-drug interactions for some patients. And ideally, you would not co-administer sparsentan with other RAS inhibitors or other ERAs or aliskiren. The risk for hypotension or hyperkalemia could be significant. And importantly, they are contraindicated in pregnancy. There will be a REMS program that is associated with the use of sparsentan that will help you remember each of these pieces. When considering the diagnosis of glomerular disease, we will have to, as clinicians, open up the age groups in which we consider this. For instance, if you have a 20-year-old otherwise healthy young man who presents to you with high blood pressure, urine protein, and urine blood, glomerular disease will be one of the first things you actually should think about. A pattern of normal GFR with an elevated urine protein and blood in the urine is very clearly to be considered as an option for glomerular disease. And importantly, while it may be considered in the outpatient setting or in the primary care setting, urinary tract infections are actually quite unusual in this age group. So therefore, again, we bring it back to considering glomerular disease as an option. And unfortunately, many of the glomerular diseases present in the teenage or young adult group. So that does bring glomerular disease up to the top of the list for consideration. For instance, one of the more significant glomerular diseases that has been reported recently is that of C3 glomerulopathy. The average age at diagnosis for C3G is 21 years of age. Therefore, clearly, we need to be thinking about this very early. Importantly, in the setting of C3 glomerulopathy, we also have to think about that young adult who may have an infection, which means that the glomerular disease could be post-infection glomerular disease, but C3 glomerulopathy looks exactly like post-infectious GN, so there is some work to do to try to sort through which one of these it will actually be. If you've considered that glomerular diseases are actually rare, it's important to maybe double think that a little bit and go back to what the literature tells us. For instance, up to 1% of kidney donors may actually have a subclinical glomerular disease, according to a Columbia study. Up to 23% of registrants in the Nurture CKD study of the UK have some form of glomerular disease as the cause of their findings. To diagnose someone with glomerular disease, the kidney biopsy is the gold standard. Not yet have we moved to being able to use any biomarkers or any laboratory studies to technically avoid the use of a biopsy. And in fact, the KDIGO, along with other organizations, have put forth some general guidelines on what a biopsy should look like and what should be considered as an adequate biopsy. Those are going to be easily available to you. The real point here is to understand that in order to understand whether you need to even begin treatment for glomerular disease or consider a targeted therapeutic, you have to start with the biopsy. And in fact, once the biopsy is done, if it's unclear to you what steps are next, it should be fairly easy for you to find a center of excellence or a glomerular disease center that can help you, well, actually do the biopsy if it's easier for you that way, but also help you think about what's the best practice or what are the next best steps for that particular patient once you understand that you're dealing with a glomerular disease. One of the most exciting advances in glomerular disease in these last couple of years, and will progress further in these coming years, is this idea of whether complement plays a role in the disease. And in fact, the poster child, if you will, of complement-mediated kidney disease is probably C3 glomerulopathy. And it's clear that dysregulated complement or overactive complement system is actually at the center of C3 glomerulopathy. And in fact, C3 glomerulopathy, as one of the diseases that has the worst prognosis over time, makes us worry that the complement's role in this disease may actually be part of the reason why the progression to end stage is so quick for this set of patients. It's also a reason for why we think about complement in the other glomerular diseases. And in fact, there is emerging data for the role of complement in IgA nephropathy, membranous nephropathy, lupus nephritis, even FSGS. And as we've known for a very long period of time, of course, complement is involved in atypical HUS. When considering C3 glomerulopathy, one major point that each of the nephrologists is going to have to work through is whether it's post-infectious glomerulonephritis. Beginning from the very beginning, we have understood that post-infectious glomerulonephritis biopsy looks exactly like C3 glomerulopathy biopsy, so that it's going to be important to try to distinguish between the two. The technical definition between the two is that if glomerulonephritis still persists after 12 weeks, or the C3 continues to be low after that 12 weeks, then we can relabel the diagnosis as C3 glomerulopathy, and then you can consider some of the newer therapeutics in that setting. The point to this really is that we recognize that even after the biopsy is collected and you've had a chance to see it, your pathologist has had a chance to see it, there still is some potential for confounding variables or confounding findings before you actually arrive at the diagnosis that you then will need to begin to treat. What is C3G? C3 glomerulopathy is a rare heterogeneous renal disease. It's often known of one of two different kinds, dense deposit disease or C3 glomerulonephritis. It is a disease of complement dysregulation. Specifically, dysregulated systemic complement activity causes C3 breakdown products to be deposited on the kidney, and that in fact is what's causing the proliferative glomerulonephritis or the inflammatory glomerulonephritis that we see classic of C3G. It may be caused by genetic variants, but more likely it is caused by acquired autoantibodies. Unfortunately, it progresses to end-stage kidney disease within 10 years in up to 70% of pediatric patients and 30 to 50% of adult patients. So you can see that the burden of disease is substantial. C3 deposition may recur almost immediately after kidney transplant, so it is not as simple as treating these patients with a new kidney. And unfortunately, 50% of allografts are lost within 10 years of diagnosis. This is all happening in the setting of standard of care. So the renal response to the current treatments is not ideal for this group of patients. Granted, these are not randomized controlled trials. They are retrospective coverage of this disease presentation or coverage of this treatment process. But in general, what we know from standard of care in C3 glomerulopathy, that roughly 30% of the young patient population respond to the standard of care, which by KDIGO currently is mycophenolate mofetil and steroids. This relative poor response to standard of care is what pushes us to actually think about more advanced therapies. And in fact, to think about more advanced therapies for C3 glomerulopathy, since the root of the disease is the complement system, we have to familiarize ourselves a bit more with the complement system. And in fact, this will be important for many of the glomerular diseases moving forward. The complement system is the front line for defense against most infections. It is rapidly activated and it has multiple immune surveillance functions. It is composed of essentially three pathways: the classical pathway, the lectin pathway, and the alternative pathway. In fact, the alternative pathway happens to be the amplification loop for all three pathways. This is what makes it an attractive target, treatment target that is, for some of the newer therapeutics. When we think about the complement pathways, we have to separate it out, and particularly some of the newer agents, we can separate it out into, perhaps think about it this way. We can think about those agents that target the terminal pathway, for instance, eculizumab or avacopan, for instance, or we can think about those that target the upstream pathway or the alternative pathway when we think about, for instance, iptacopan or pegcetacoplan. Many of us are a little bit more comfortable with the terminal pathway because that's the pathway that we've been able to address, since 2011, 2012 with the terminal complement blockades. But it's the upstream or alternative pathway where some of the newer therapeutics are going to be seen. When it comes to choice of drug, it's not only going to be based on mechanism of action, which I think is a very important place to start, but your patient preference may also make a difference. For instance, just using ravulizumab and eculizumab as an example, the fact that ravulizumab is actually infused less frequently has made it perhaps a bit of a favorite, if you will, for patients. We can assume this pattern will exist in future therapeutics in that there will be patient preferences. So what do we know about the efficacy of some of the newer therapeutics, particularly the anti-complement therapeutics in C3G? First, I'm going to share with you the pegcetacoplan phase 2 trial. This actually was a basket study that included C3G, IgA nephropathy, lupus nephritis, and membranous nephropathy. In all 4 of the cohorts, they saw a reduction of urine protein, and particularly for the C3G cohort, they saw a 50.9% reduction in proteinuria within 48 weeks. How about iptacopan, the factor B inhibitor, also has been published data. This is a phase 2, 12-week study in which they followed C3G patients. Importantly, they saw a 45% reduction in the urine protein. Again, this is additive on top of what you're seeing in supportive cares or in standard immune suppressants, if you will. And a median C3 deposit score decrease. So the amount of C3 being deposited on the biopsy was decreased by a factor of 2.5. I think there were some important findings with respect to the GFR. The mean pre-treatment estimated GFR slope in the native cohort was minus 16, approximately minus 16. After treatment, the GFR actually improved by 4.9. So I think you can see not only are we seeing reduction in C3 deposition, the actual definition of the disease, but also a reduction in urine protein and an improvement over the historical GFR. We now have the advantage of the 33-month outcomes for that iptacopan trial, and 42.9% of patients met what they were considering their composite endpoint, and that was a stabilized GFR, or meaning less than or equal to 10% change in the GFR, or a greater than or equal to 50% reduction in urine protein. So 42.9% of patients at 33 months met the composite score. This is very important for us as clinicians because we now understand that not only is the clinical changes that are important are stable, persistent, important outcomes, but also we now know that out to 33 months that we have a safe approach to treatment. IgA nephropathy is a progressive form of CKD and the most common form of primary glomerulonephritis in the world. It progresses to end-stage kidney disease in about 30 to 45% of patients within a 20 to 25-year period. And it is marked by dominant or co-dominant IgA staining on biopsy. So again, you're finding out that biopsy is going to be very important. IgA, the mechanism of action or the mechanism of disease for IgA is believed to be a 4-hit hypothesis. The first hit being galactose-deficient IgA production. Then we have the second hit is IgG that's being formed against that abnormal IgA. Then we have the immune complexes actually form between these two. And then finally, you have the deposition of these immune complexes on the kidney. So this 4-hit hypothesis is been fairly well accepted. And this is how we understand the pathogenesis of IgA. Keep that in mind when we think about therapeutics that are coming to the fore. As with any of our glomerular diseases, we're going to start with supportive cares, and that are the same supportive cares that we've used in other glomerular diseases. So blood pressure control, urine protein control, smoking cessation, etc. All of these things are going to be important for our first aspect of treatment of IgA, and they will very frequently, as stated in KDIGO, include ACE inhibition or ARB. When we think about future therapeutics, they come in essentially 2 different varieties. The first one is, of course, the complement inhibitors have come to the IgA world also. We're seeing blockade of the alternative pathway to be potentially important at this setting, and we're going to provide a few of those studies for you. But we're also seeing two other brand new agents, APRIL and BAFF inhibitors. And so APRIL is a proliferative inducing ligand. It regulates B-cell mediated immune responses. So you can think, if you think about that hit 1 and hit 2, APRIL blockade may be very important in IgA, for instance. Or BAFF, B-cell activating factor. BAFF controls the maturation and survival of B cells. So again, thinking about HIT 1 and HIT 2, you might see an opportunity for why BAFF may be useful in this setting. Etacicept reduces proteinuria in IgA nephropathy. This was the 24-week results for this agent, and what they saw was 25% reduction in urine protein from baseline at 24 weeks. This is an important finding when you think about this more targeted approach for IgA nephropathy. And again, this is on top of standard of care. GFR was also stabilized in this group, whereas it declined in the placebo group. So again, you're seeing that this is an additive effect. How about zigakibart? It also reduces proteinuria in IgA. This is the 2-year results from a phase 1/2 study. They saw up to a 72% reduction in the urine protein in this group of patients. This was a 24-hour urine protein, by the way. And this indicates to you that this is a sustained clinical benefit for the use of this targeted agent. Zigakibart for IgA, the BEYOND study, is the phase 3 clinical trial. We anxiously await the results of this study, and if they reproduce what they saw in earlier studies, this also will be an important addition to our IgA treatment regimens. Sibeprenlimab reduces proteinuria and serum IgA levels in IgA nephropathy. It's important to know that these newer therapeutics also reduce the IgA level, which is believed to be one of the pathogenic mechanisms of disease, along with the clinical improvement of proteinuria. The ENVISION study is a phase 2 study, and their results suggested that they were able to not only see the reduction of that IgA, but also see an improvement in the 24-hour urine protein, depending on what the dose given was. RG6299 is a factor B inhibitor. It has shown to reduce complement levels and proteinuria in patients with IgA. These are the phase 2 interim results where they had a 47% reduction in 24-hour urine protein, a 69% reduction in plasma factor B levels, and a 92% reduction in urinary factor B. Iptacopan, the factor B inhibitor, has also been shown to be useful in primary IgA nephropathy, and the results for the phase 2 study are as follows. They had a 23% reduction in urine protein to creatinine ratio with the 200 milligram BID dosing at 3 months. The urine protein to creatinine ratio was also further reduced at 6 months in both the 100 milligram and the 200 milligram arms. The iptacopan in primary IgA nephropathy interim analysis results of the phase 3 APPLAUSE have now been released, and in this setting, we also saw that iptacopan could reduce the urine protein above baseline therapies in this group of patients. What is membranous nephropathy? Well, first, let's start. The clinical hallmarks of disease are the nephrotic range proteinuria, low serum albumin, and edema. This is classic presentation for this group of patients. The exact mechanisms are not fully understood for this disease, but they include genetic factors, environmental factors, loss of immune tolerance to some particularly specific autoantibodies, and perhaps even complement activation, resulting in glomerular inflammation and cellular adaptive processes not responding appropriately in the glomerulus. Most patients have an anti-PLA2R antibody. There are many other antibodies that have now been diagnosed. And importantly, 40% chance of recurrence post-transplant. So you can see that despite standard care now, we have patients who are continuing to get a membranous nephropathy and progress to end-stage kidney disease with membranous nephropathy. How is membranous nephropathy managed? Well, we can go back to the KDIGO guidelines, which often start with supportive care. So this is a group of patients that you will begin with good blood pressure control. You are going to try a lot of our supportive measures, which include ACE inhibition, some of the newer endothelin blockers, for instance. You're going to do weight control, smoking cessation, etc. You're going to do all of the usual supportive things. And then referring to KDIGO, very frequently you're going to use agents such as rituximab or cyclosporin according to that treatment pathway. But what you will note very quickly that is up to 40% of patients are non-responders to this approach to treatment. So what is the role of complement in membranous nephropathy? Well, This study shows us that there is C3, C4, and membrane attack complex deposited on the kidney in patients who have membranous nephropathy. The presence of these complement factors is highly suggestive that complement is active in this disease and that complement may in fact be a target for treatment. If we consider our complement pathway, it's important to remember where complement may be active in membranous nephropathy. For instance, if membrane attack complex is the primary complement activity you are noting in a membranous nephropathy patient, it makes sense to consider terminal complement blockade. And we are thinking at that point things like eculizumab, ravulizumab, or even avacopan for a particular glomerular disease. But if you are thinking about C3 deposition or even C4 deposition, it may make more sense to move up the pathway to the alternative pathway and consider something like iptacopan or pegcetacoplan in a membranous nephropathy patient. In fact, pegcetacoplan reduces proteinuria in patients with membranous nephropathy. Membranous nephropathy was involved in the basket trial that was done for pegcetacoplan. Remember, this is a C3 inhibitor, and for all cohorts, including the membranous nephropathy group, the urine protein was reduced. Factor B inhibition via iptacopan is also now being considered in idiopathic membranous nephropathy. We expect that if the complement system is involved in this disease, as has been shown, that we will also see a clinical benefit with factor B blockade. So what are our key takeaway points when we consider complement inhibitors in glomerular disease? First, very frequently, at least now, they will be additive to current standard of immunosuppression, and the choice of standard immune suppression treatments varies according to the glomerular disease. Whether we will eventually move to using complement inhibitors as a primary therapy remains to be seen. Importantly, kidney biopsy will always be important, not only for the ultimate diagnosis of the glomerular disease, but also follow-up of the glomerular disease patient. Complement inhibitors are targeted treatments, unlike some of our what we'll call nonspecific immune suppressants or even our supportive cares. But importantly, not all complement inhibitors are alike. Depending on what the glomerular disease baseline pathology is, it may make more sense to use a given complement inhibitor for a given glomerular disease. Something we must not also forget is this concept of how can we prepare our patients to be safe with the use of complement inhibitors or with some of the newer therapies, whether they have a different mechanism. And particularly vaccination against encapsulated organisms is going to be essential in this group of patients and will be probably required before you can even use those agents, particularly the complement inhibitors. And then finally, at this time, clinical abnormalities still drive our care. For instance, I mentioned the possibility that at some point, some of these newer agents may be primarily used instead of what we now consider to be standard immune suppression. But they still, at least at this time, will be used based on clinical abnormalities, not based on biomarker abnormalities. That concludes our discussion for today. I hope you've found the activity informative in advancing your understanding of the complement-mediated kidney diseases. And I hope you feel more confident about how to treat glomerular disease in general, but will be excited along with me to be watching for the new developments that some of these newer agents can bring to our patient population. Thank you for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XWR860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.